رئيس المؤتمر شخط فيا وقال لي اطلع اقعد، يعني احنا بنخاف من الراس. It's my pleasure to co-chair this session مع الاستاذ الدكتور محمد عوض ابراهيم. اتفضل دكتور محمد.
بسم الله الرحمن الرحيم. الحقيقه كل الشكر والتقدير لاستاذي الفاضل استاذ دكتور طارق صفوت، استاذ ورئيس المؤتمر ورئيس الجمعيه المصريه للشعب الهوائيه لمجهوده العظيم. فالف شكر لحضرتك دكتور طارق، بنتعلم منك دايما الذوق والاحترام والجديه والاخلاص، كل الصفات الحلوه. بيشرفنا النهارده الحقيقه معالي الوزير استاذ دكتور اشرف حاتم، وهو فخر لكل اعضاء الامراض الصدريه ايا كان اعضاء التدريس او اطباء في الصحه. معالي الوزير كان وزير الصحه وامين العام للمجلس الاعلى للجامعات حاليا، وده شرف لينا كلنا كاطباء صدر. فاهلا بيك معالي الوزير. It is a great honor for me to co-chair with Professor Adel Khattab, and we are going to an interactive session which is very, very interesting for interactive case presentation. Firstly, Ain Shams case presentation, Professor Jihan Al-Assal. Yes.
دكتورة جيهان، انت عارفه احنا يعني اصدقاء واخوات قد ايه. انا بستأذنك، وكويس انك انت اول سبيكر من عين شمس، ان احنا we are 40 minutes behind the schedule.
اوكي.
والسكادجول النهارده متاخر، يعني فالامور هتمتد، فبليز stick to the time.
بسم الله الرحمن الرحيم. الاول طبعا بشكر اللجنه المنظمه للمؤتمر لدعوتي للمشاركه معاكم. بسم الله الرحمن الرحيم. عين شمس case presentation. A male patient 4 years old, born and lives in Al-Fayoum. He was complaining of shortness of breath. The condition started 40 days before admission with gradually progressive dyspnea and fever, after which medical consultation was done. His grandmother stated that all his symptoms started few days after falling on the ground after a donkey ride. Chest X-ray was done and diagnosed as pneumonia for the patient. This was the chest X-ray, after which antipyretics and bronchodilators were prescribed, but the clinical and radiological picture didn't improve. So CT chest was done at Omraneh Chest Hospital. This was the CT chest done for the patient. These different cuts in it. He stayed for about 2 weeks in Omraneh Chest Hospital on pediatric ordinary ward on medical treatment with no further intervention and no improvement. Then he was transferred to the ICU after complaining of severe respiratory distress and hypoxemia. The child was immediately mechanically ventilated. 2 days later, he suddenly arrested and returned back after 7 minutes of CPR. 2 days later, bronchoscopy was done in the ICU through the endotracheal tube and revealed the following: a mass tissue totally obstructing the left main bronchus. The day after, he was transferred to the chest department in Ain Shams University Hospital for rigid bronchoscope. Rigid bronchoscope was done, through which partial debulking using electrocautery and argon plasma coagulation was done. حضرتك اتفضل. وحدة البرونكوسكوب عندنا في عين شمس، ده تكملة للسيشن اللي فاتت. was done, revealed blood clots at the origin of the left main bronchus, pulsating structures and debris. The debulked tissue looked more like a granulation tissue. Actually, a tear in the left main bronchus was then discovered after removal of all the governing tissue. This is the post-bronchoscopic chest X-ray. Unfortunately, subcutaneous left-sided infraclavicular surgical emphysema was noticed, so a call for surgical intervention was done. It was a diagnosis dilemma, actually. Is it left main bronchus avulsion, huge contusion of the left whole lung, or a combined pathology. Patient was immediately transferred to the thoracic surgery department for exploration. In the operative, posterior lateral left thoracotomy was done, revealed moderate hemothorax, rupture of the left upper loop, collapse of the left lower loop plus central contusion, longitudinal tear along the length of the left main bronchus immediately beneath the arch of the aorta. This is intraoperative photos. Repair of the left main bronchus was done. Left upper lobectomy, it was abnormal, huge voluminous loop. Contused left lower lobe was spared to avoid pneumonectomy in a 4-year-old child, expecting good expansion for this lobe. Final extubation immediately was done after surgery. Surgeon insisted to examine the lobe histopathologically. This is the post-operative chest X-ray. The histopathological report stated that it was lung tear, acute inflammation, interstitial hemorrhage with no malignancy. 5 days post-operative, the patient was discharged out of the department in a very good state. But actually, the storm was not over. 5 months later, after complete loss of follow-up, the child reappeared with a very bad general condition, severe dyspnea, tachycardia, symptoms of heart failure. Emergency CT scan for the chest was done. This is the picture of the CT. اتفضل. What is the suggested next step for you? It's a question for you. Please answer it. Tapping of the reaccumulated hemothorax, intercostal tube to drain the reaccumulated hemothorax, or re-exploration of the patient. Please vote. هي الجراند ماستر قالت ان كل البروبلم السيمتوم ظهرت بعد دونكي رايت. Result actually more than 58% to go with re-exploration, which was actually happened. The operative details. Emergency exploration was done. On rib spreading, rupture of the thoracic content, massive pleural collection of vascular soft tissue, debris, and remnants of the left lower lobe, which was spared in the first operation. In this mess, in a highly vascular redo surgery, the surgeon had to search for the major great vessels after 6 hours intraoperative. 1 hour to separate very fragile pulmonary artery from the bronchus without causing catastrophic fatal bleeding. Completion pneumonectomy was done, plus evacuation of the whole thoracic content, including whole lymph node stations. Immediate extubation after relief of the compression symptoms. The child regained his normal health and resumed playing football in the department. All were waiting for the histopathological report. In your opinion, histopathological examination revealed organized reaccumulation hemothorax, rhabdomyosarcoma, traumatic avulsion of the bronchus, or osteosarcoma. Actually, most of them goes with traumatic avulsion of the bronchus. However, the diagnosis of histopathology was rhabdomyosarcoma, infiltrating the pleura and the lower loop. No metastasis deposit in the regional lymph nodes. In our opinion, it's progressed like that. Undetected rhabdomyosarcoma, coincident with severe trauma, with fault pathology, actually with no available frozen section during the surgery, lead to misdiagnosis. Then after local recurrence, we reach the definite diagnosis. Rhabdomyosarcoma is extremely rare. Rhabdomyosarcomas are malignant tumor of the skeletal muscle. Can occur in various age groups, the majority in infants and children from the age of 1.5 years to 14 years. Many that arise in children are associated with cystic adenomatoid malformations. Treatment is surgical resection, usually combined with chemotherapy and radiation therapy. With proper treatment, approximately 2/3 of the patients have no evidence of disease at varying periods of follow-up. Thank you.
Thank you دكتورة. Thank you دكتورة جيهان. We'll proceed لأن احنا short of time. الحالة الثانية الدكتورة عصام جودة هو في الطريق إن شاء الله يلحقنا قبل ما نخلص الجلسة. ما يقول بروفيسور سمرة. سيب الدكتور عماد بروفيسور سمرة هي عشان ده عندها حالة. بروفيسور سمرة هتقدم الحالة من إزمير.
Dear colleagues, dear friends, this is a 55-year-old female, a housewife. Her complaints are hoarseness, dry cough, weakness. Dry cough and weakness for the last 2 years. Hoarseness was for the last 6 months. There was no diagnosis made by past ear, nose, throat doctors and pulmonologists after the workups. And she was, at the end, referred to our hospital and was admitted for further diagnostic workup and treatment. The patient was a diabetic for the last 5 years and was on oral antidiabetics. She had appendectomy 20 years ago. She never smoked. She didn't have any bad habits, and she had 1 BCG scar. On physical examination, her vitals and system examination was normal. Respiratory systems were normal, just excluding dysphonia. The only pathology in the examination was dysphonia. Lab work, routine blood tests, pulmonary function tests were within normal limits. PPD 7 millimeters, HIV negative, beta human chorionic gonadotropin and alpha fetoprotein were negative. This is the chest X-ray showing a mass that is contiguous to the mediastinum, extending from the right paratracheal area to the infrahilar area on the right, and the lateral border of the mass is very easily distinguished from the lung. On chest CT, this 6 centimeter mass was in the upper right mediastinum, was extending from the right paratracheal area to the right main pulmonary artery, had cystic and solid components, and was not invading neighboring structures. At this stage, what would you do? Transthoracic needle biopsy, convex probe EBUS TBNA, conventional TBNA, give empirical antibiotic treatment, mediastinoscopy, and/or thoracotomy. Please vote. Most of the answers go to mediastinoscopy and/or thoracotomy. There is no real correct answer here. There can be many different answers. We did conventional TBNA. And on flexible bronchoscopy, there was paresis of the right vocal cord. There was compression in the right distal paratracheal area. Carina was blunted and fixed, and right upper lobe bronchus had hyperemia and edema. And we did 19 gauge conventional TBNA, which gets histological samples. And we did it on the right paratracheal area, carina, and right upper lobe bronchus. And we did also endobronchial biopsy from the right upper lobe bronchus mucosa. Pathology for the bronchial washing fluid was benign. TBNA specimen was mostly necrotic, had some minimal granuloma, and endobronchial biopsy resulted fibrotic. Here we see the 19-gauge conventional TBNA specimen with a lot of necrosis on this part, and there are a few granulomas on the side. Microbiological examination for bronchial washing fluid, AFP, non-specific bacterial or fungal cultures negative, TB cultures pending, TBNA specimen, AFP negative, non-specific bacterial or fungal cultures negative, TB cultures are pending. What would you do at this stage? Repeat conventional TBNA, convex probe EBUS TBNA, transthoracic cutting needle biopsy, anti-TB or antifungal treatment, mediastinoscopy, and or thoracotomy. There is no real answer. I mean, there can be many options for answers. Most of the answers again go to surgical intervention, mediastinoscopy and or thoracotomy. We did convex probe EBUS TBNA. And there were the same bronchoscopic findings, of course. EBUS TBNA was performed from the 4R, 7, 10R, and 11R stations. The pathology of the EBUS TBNA specimen on smear and cell blocks showed V9 cytology, a lot of necrosis, and a few dysplastic cells. The bacteriological examination of the EBUS TBNA specimen was negative for AFP, for non-specific and fungal cultures, and TB cultures were pending. And this is the EBUS TBNA specimen showing a large area of necrosis, non-specific findings on this side, a few dysplastic cells. We did PET CT. It showed hypermetabolic FDG accumulation in the semi-solid mediastinal mass with a ametabolic center. And the FDG accumulation was also seen in the right retroclavicular, right inferior jugular, esophageal, and prevascular lymphadenopathies. This is the PET CT showing the mass extending from the root of the neck to the paraesophageal area on the right. It's it's going very downwards. It's a huge mass with some lymphadenopathies around. And with these findings, what would you do? Repeat EBUS TBNA, transthoracic cutting needle biopsy, mediastinoscopy and or thoracotomy, anti-TB treatment, antifungal treatment. Most of the answers go to mediastinoscopy again. This audience is very persistent, yes, and aggressive. There is no real correct answer again. We did anti-TB treatment. We started anti-TB treatment. And why did we start anti-TB treatment? Because the conventional TBNA and EBUS TBNA specimens were benign, had a lot of necrosis, and conventional TBNA specimen had some granulomas. Thoracic CT showed the characteristic features of TB lymphadenitis with the rim around, and there is a necrotic hypodense area in the middle. The patient was a diabetic, and as we know, tuberculosis incidence and the atypical tuberculosis is high in diabetics, and patient was strongly against surgery. She refused. And then we gave isoniazid, rifampicin, pyrazinamide, and ethambutol. However, 1 month of directly observed anti-TB treatment resulted in nothing. She had weight loss, cough, dysphonia, fever, no radiologic regression. At this moment, at this time, she was not against surgery. We consulted thoracic surgery for definitive diagnosis and treatment. And surgery they don't accept easily. They said you need thoracic MRI. So the mediastinal mass on thoracic MRI had no contrast accumulation in the wall, no vascular origin, no invasion in the neighboring tissues. It was resectable. On thoracotomy, total excision of the mediastinal mass and lymphadenectomy was done. Frozen sections had granulomatous inflammation. And the gross pathology of the surgical specimens showed the mediastinal mass and the paraesophageal lymphadenopathy had necrotizing granulomatous inflammation suggestive of TB. The EZN stain was negative for AFP in these tissues. And the surgical specimen is here, a lot of granulomas and the necrotic part. Another part from the specimen, granulomas, necrosis, and at high magnification, the surgical specimen. Anti-TB treatment was continued with isoniazid, rifampicin, morphizinamide, and ethambutol postoperatively. In the follow-up, dysphonia and other symptoms abated. No complaint and complication developed. A week or 10 days after surgery, conventional transbronchial needle aspiration specimen had growth of Mycobacterium tuberculosis on culture, and there was no resistance to anti-TB drugs. Very surprisingly, EBUS TBNA specimen on culture did not grow any Mycobacterium tuberculosis. It should be expected. And the thoracic CT after 6 months of anti-TB treatment was almost normal. There were a few scar tissues from the surgery. She was doing fine. Why the case was presented? Because in mediastinal tuberculous lymphadenitis, conventional TBNA has diagnostic efficacy. And the tuberculous lymphadenitis findings may imitate, rarely, malignancy with dysphonia, blunted fixed carina, 6 centimeter mass, and the surgical treatment is required if there is compression and complication, and if there is no response to anti-TB treatment. Rare occurrence is seen in adults. It's mostly children's disease, or it's seen in immunosuppressed patients. And CT findings are characteristic with a peripheral rim and central low attenuation and necrotic part in the middle. If I have time, I can continue or I can stop. Continue. I will give some information very short. When we look at the primary mediastinal tumors, anterior mediastinum most frequently has timomas and the others. And in the anterior mediastinum, we can have benign lymphadenopathy, tuberculosis, sarcoidosis, silicosis, and mycosis. And our case was tuberculous. And in middle mediastinum, lymphoma and mediastinal cysts are mostly seen. And in the posterior mediastinum, neurogenic tumors. And mediastinal tuberculous lymphadenitis is a children's disease, a component of primary tuberculosis. It's mostly seen in Eastern countries more than Western countries. In adults, it's rare as isolated lymphadenopathy. It makes only 1.3% in all tuberculosis cases in adults. Whether it's primary infection or reactivation in adults is controversial, but in our case, I believe she had BCG scar. Our case was reactivation tuberculosis in the form of tuberculous lymphadenitis because she was a diabetic. Asians, Africans, immigrants have this disease more than the others. Immunocompromised state is important, and diabetes mellitus is a risk factor. Symptoms are non-specific. Diagnosis can be difficult if pulmonary TB is absent. Age can be any age. Most of the time it's 45. Females have it more. And the peripheral part, the rim enhancement, center has low attenuation, necrosis. It rarely invades neighboring tissues and imitates malignancy. Location is most of the time anterior upper mediastinum and right side, as in our patient. Mass is rare even in children and in adults. TB lymphadenitis mass can invade compressed mediastinal structures, causing symptoms of dysphonia, dysphagia, dyspnea, dysrhythmia. And PPD may be positive. Bacteriology and pathology can be obtained from the bronchoscopic or other specimens, and AFP should be looked for in the tissue. Treatment is the same as pulmonary tuberculosis treatment. Lymphadenopathy and mass may not shrink, but enlarge despite effective treatment. If compression and complication occurs, resection may be required in addition to anti-TB treatment. Thank you for your attention.
Very thanks, Professor Semra, Izmir University, Turkey, for her excellent presentation and conflicting case. Now we are going to the third case presentation, Professor Muhammad Saeed, القصر العيني University.
بسم الله الرحمن الرحيم. السلام عليكم. أنا محمد سعيد، مدرس في القصر العيني. في الأول طبعا ده شرف كبير ليا إن أنا بقدم حاجة في المؤتمر الكبير. أحب أشكر اللجنة المنظمة وبشكر أستاذي الأستاذ دكتور أشرف حاتم إن اداني الفرصة دي. اخترنا لحضراتكم من الحالات اللي كانت بتحجز عندنا في الاسم في القصر العيني حالة شورت. He is a male patient, 38 years old, born and living in Monrovia, married with 3 offspring, worker at a petrol company, ex-smoker from 1 year, and he used to smoke 2 packs per day for 15 years. Came to us complaining of shortness of breath. The story of the condition started 3 years ago in the form of dyspnea of gradual onset and the progressive course, not associated with wheeze, orthopnea, or paroxysmal nocturnal dyspnea, to be a moderate exertion upon presentation and admission in our department. Condition كان معاها cough expectoration, minimal amount, white to yellowish in color, odorless, with no diurnal posture variation. قبل ما يجي عندنا كان صوت medical advice at the private clinic. اتقال له ان الموضوع ده ليه علاقه بالمكان اللي انت شغال فيه، بس ما اتقالوش ترم واضح انت اسما ولا COPD, and was given non-specific treatment, antibiotic or bronchodilator for about 6 months, and then referred to another place. He changed his place of work. The condition became partially improved regarding the cough and the dyspnea. Till 6 months ago, before admission, the patient developed blood-tinged sputum associated with some constitutional manifestation in the form of low-grade fever, mainly at night, without night sweating, but there was loss of appetite with loss of weight. He lost about 10 kilograms in the last 2 months. The patient sought medical advice at a private clinic. كل ده قبل ما يجي لنا. عمل chest X-ray، عمل CT chest، لقوا lesion، خدوا منه CT guided biopsy و CT guided fine needle aspiration من right lung from the back, and according to the biopsy result he started anti-tuberculous treatment. كان عارفهم، خد ريماكتازايد، ethambutol، باريزينامايد، وحطوا عليهم كمان oral steroid which he took for 3 months without any improvement. بعد ما فيش تحسن في الحالة he was referred to our department for further investigations and management. Past history والfamily history كانوا negative أو irrelevant. On examination, patient كان تقريبا كله free، بس هيد neck examination كان فيها jaundice، الupper limb كان فيه first degree clubbing والlower limb كذلك، الليفر بتاعه كان كبير شوية، كان firm inconsistency وكان tender إلى حد ما with rounded border. cardiological examination لحد ما كان free. local examination كان كله free إلا بس الأوسكالتيشن بتاعه كان فيه bilateral vesicular breathing، inspiratory medium size crepitation على الانفرامامري والانفراسكابولار areas bilateral. انا حبيت اعرض الحاله دي بالصوره دي لان ده اللي احنا بنشوفه يعني بيجي لنا في القسم او بيجي في العياده بره، فبناخد منه الهيستوري الاول. وطبعا طبعا الاكس راي بقى سهل والسي تي، بس احنا عايزين نقول برضو دور الهيستوري والاكزامينيشن. كديفرنشال دايجنوز بالنسبه لي الهيستوري ما كانش سو انفورماتيف. بوست بيشنت اللي بيجوا لنا بيجوا بديسنيا وكوف واكسبكتوريشن، فبالتالي الديفرنشال دايجنوزس السكيل بتاعه هيبقى كبير، انترستيشيال، حاجه في الاير واي، حاجه في البلورا، وهكذا. فعشان كده هنطلب طبعا انفستيجيشن. دي الاكس راي اللي عملها من 6 شهور، وبعدين على اساسها طلب سيتي تشيست. بالنسبه لي زي ما حضراتكم شايفين هو في بايلاترال اسيمتريكال ليجن مور على الرايت سايد ان ذا فورم اوف ريتيكوليشن، ممكن يكون باتشي اوباستي، ممكن نقول ان في نيمونيا مثلا في الميدل لوب او في اللور لوب، وفي زيها برضو في الليفت بيز. السيتي تشيست اتعمل زي ما حضراتكم شايفين هو في alveolar filling process موجود في الميدل لوب وموجود في اللور لوب على الناحيه اليمين والشمال، متركز اكتر في البيزل سيجمنت اكتر على اليمين من الشمال، بس واخد تقريبا الديستريبيوشن بتاعه بيزلي. ده الميديستاينال ويندو، ما كانش فيه ميديستاينال ليمفادينوباثي يعني ذو قيمه. الاير برونكوجرام باين. دي صوره كان جابها لنا معاه وهو جاي، ده الفاين نيدل اسبيريشن اللي اتاخد من الرايت سايد من الباك. فكان ده الباثولوجي بتاعه، قال ان هو يعني الخلاصه ان هو جرانيوماتس بروسيس، معاهم حق يبتدوا تبركلوزس في واحد في مصر وجرانيوماتس، وكان جايب كونستيوشن مانيفستيشن هيموبتس ولو جريد فيفر او نايت فيفر، بس ما كانش معاه نايت سويت. بعد ما خد التريتمنت 3 شهور عادت شيست اكس راي، دي الاولانيه. الثانيه اظن ان الليجن زاد على انتي توبركلوز، حتى كمان كان معاه ستيرويد كانتي انفلاماتوري فلودوز. الليجن زاد برضو اكتر على اليمين على الشمال، لكن في مجمله زاد، والبيشنت كلينيكالي ما اتحسنش. طيب سي تي تشيست اتعمل بقى لما البيشنت جه عندنا، هنبص نلاقي مور ليس ذا سيم، او يمكن حتى زاد حاجه بسيطه، بس هو ما اتحسنش على 3 شهور انتي توبركلوز، ودي فتره كافيه لو هو توبركلوزس كان البيشنت اتحسن. ده الميديستاينال ويندو ليجن بايلاترال اسيمتريكال، مور على الرايت سايد، واخده ميدل ولور على الرايت ولور على الليفت. بالنسبه لي دي الفر فيرنج، يبقى احنا بنتعامل مع حاله ان ريزولفنج بايلاترال نيمونيا. طيب اللابس بتاعته هو كان ليتل بيت انيميك، التوتال اكسيد كاونت كان عالي، الايزينوفيلز ما كانتش عاليه، تمام، لان برضه ممكن تخش في الديفرنشال دايجنوز اوف ان ريزولفنج نيمونيا ايزينوفيليك نيمونيا. الكومنت بتاعها كان هايبوكروميك ماكروسيتيك انيميا، يعني ما كانتش انفورماتيف بالنسبه لنا او توصلنا لديفينيت دايجنوزس. كان عنده ليفر انزيمز عاليه، احنا رجعناها للانتي توبركلوس اللي كان بياخدها، وكان فيها طبعا بارازينامايد واي ان اتش وريفامبسين. لما وقفناها فعلا اتحسنت. اي اس ار يعني ميد واي عالي قوي، مثلا يدخلني في قصه كولاجين او مالجنسي، ممكن نحط برضو برونكو ارفر كارسينوما في الديفرنشال دايجنوزس، ما ادانيش برضو عاد نافع. الفيرست اور 40 والسكند اور 60. البلاد جاز بتاعته البي اتش كومبنسيتد والبي سي او 2 والبي او 2 بتاعه هو قليل البيت هايبوكسيك اكوردنج تو هيز ايج، لكن مش في ريسبيراتوري فيلير. التوبركلين تيست بتاعه كان نيجاتيف، الكوانتيفيرون كان نيجاتيف، سبيوتم فاست نيجاتيف 3 دايز، سبيوتم كلتشر ما طلعتناش حاجه 3 مرات برضو، كل مره كانت بتبقى ساليفري. عملنا له اتش اي في كان نيجاتيف، سي فيروس هيباتيتس سي فيروس نيجاتيف، سايتوميجالو والاي ان اي والانك بتوع الكولاجين ديس اوردر كانت نيجاتيف برضو. لما عملنا له سونار نطمن على الليفر بتاعه، طلع لنا هيباتوسبرين وميجلي، وزي ما قلت لحضرتك احنا قلنا ان الليفر انزيمز والجوندس كانت عاليه، او الجوندس كان موجود نتيجه الانتي توبركلوس ثيرابي. طبعا الخطوه اللي بعديها اكيد هنعمل برونكوسكوب. البرونكوسكوب عايزين ناخد لافاج فور كالتشر فور سيتولوجي، ممكن ناخد ترانس برونكال بايوبسي، ممكن نتفاجئ بحاجه مثلا ميكوزا نوديول ساركويدوزس او وات ايفر. البرونكوسكوب كان اول فري، خدنا ترانس برونكال بايوبسي وبال من الرايت لور لوب فور هيستوباثولوجي، ودي المكان اللي هو كان الليجن اكتر فيه، ومتوقع لو طلعنا حاجه هتبقى من الرايت لور لوب. سيتولوجي واز تيكن اسيد فاست باسيلاي اند كلتشر فور بكتيريا، كلتشر فور ايروب اند انيروب اند كلتشر فور فانجل. culture and sensitivity was not informative. شويه بس cells وابيثيال cells negative for acid fast, negative for bacteria and negative for fungal. البال cytology was not informative. Mycoid background with RBCs, lymphocyte, macrophage, polymorph 3 plus squamous cells، فقالوا دي inflammatory smear. برضه ما وصلناش لحاجه. لكن ما خدنا ترانس برونكيال لانج بايوبسي من الرايت بيز، كان ده الجروس بيكتشر بتاعتها، قالوا سنجل جرايش وايت تيشو فراجمنت 0.2 سنتيمتر توتالي سبميتد باي مايكروسكوب. It revealed lung tissue showing chronic inflammatory celial infiltrate with foamy macrophage and lipophage. Had no evidence of tuberculosis or malignancy, and the conclusion was it is a bilateral parenchymal infiltrate. Bronchoscopic biopsy gives the picture consistent with this picture. It's a picture of lipoid pneumonia. لما نرجع للهيستوري، البيشنت كان شغال في شركه بترول، كان شغال عامل، بس اكيد طبعا بيتعرض للفيبرز بتاعت البترول. سلايدز بسرعه عن الليبويد نيمونيا. It is an uncommon condition. هي في الأول وفي الآخر نيمونيا، بنتعامل معاها احنا a case of unresolving pneumonia. It is an uncommon condition result from pulmonary accumulation of fat-like compounds of animal، يعني الألفيولاي بيبقى جواها lipid، يا إما من vegetable or animal or mineral origin. Can be classified into endogenous أو exogenous according to the source of the lipid. الليبيد جاي من جوه من السيل نفسها من جوه الإنسان، ولا الليبيد جاي من بره من الانفايرومنت اللي حواليه. فالاندوجينوس بنسميها برضو ساعات كوليسترول او جولدن نيمونيا، وده شكلها تحت السلايد، ده شكل الليبيد بيبقى شبه بيبقى يلو شويه. The fat-like materials are derived from the lung itself. بتحصل في حالات ان مثلا لو في اندوبرونكيال ليجون عامل اوبستراكشن ديستالي، فبيبتدي الكوليسترول والايسترز اللي موجوده في الالفيولار سيلز تكسترافازيت بره وتخش في الالفيولار سبيس. بتحصل في حالات سابراتيف لانج ديزيز، بتحصل في حالات الليبيد ستورج ديزيز. The exogenous form can be classified into acute and chronic، والحالة بتاعنا كانت exogenous lipoid pneumonia. الchronic results from long-term recurrent inhalation and exposure to oil. الأكيوت ده تعرض لدوز عالية قوي من الأويل vapors. Exogenous lipoid pneumonia caused by inhalation of oil present في الفود أو radiographic contrast media أو oil-based medications such as laxative. اتوصفت في الأولد ايج اللي بيستخدموا، أو كمان في الانفنتس اللي بيستخدموا البارافين أو بيستخدموا تقريبا الشوق أو زيت الخروع for treatment of constipation. برضه في الفاير ايترز اللي بنشوفهم في الافلام اللي هم بيحطوا بقهم كيروسين وبعد كده بيولعوا وبيبخوا نار، ده برضه اتوصفت فيهم. Less commonly reported causes كانت من aspiration of milk, poppy seed oil, incubation, exposure to paraffin, use of spray paint and whatsoever. Factors that increase the risk of exogenous lipoid pneumonia لقيت ان هي نفس الريسك فاكتور بتاعت الاسبيريشن. extremes of age, anatomical or structural abnormalities في الفارنكس زي الذكر diverticulum والريفلكس والجيرد يعني. psychiatric disorder, episodes of loss of consciousness and neuromuscular disorder. الاويل بيفلوت على التوب اوف ذا ستومك، الستومك فيها فلويد ووتري، هو بيفلوت على التوب، عشان كده الريسك او الانسيدنت بتاع الاسبيريشن بتاعه بيبقى اعلى. aspiration of mineral oil، الاويل ده inert يعني التيشو مش رياكتنت قوي للتيشو او مش irritant للتيشو، فعشان كده الاسبيريشن بتاعه بيبقى بسهوله، البيشنت لا هيكح ولا هي يعني مثلا هيخش في ازماتيك اتاك او حاجه، فبيبقى silent aspiration. The clinical symptoms non-specific زي أي disease، مثلا زي chest infection ممكن يجي بلو جريد فيفر، ممكن يجي بكوف باكسبكتوريشن. في الحالات الكرونيك طبعا هيجي لنا في الآخر بديسنيا. Chronic cough sometimes productive and dyspnea. Less commonly chest pain, hemoptysis, weight loss, intermittent fever. Physical examination برضه عمره ما هيقول، يعني عمري ما هكشف على البيشنت مثلا في العيادة وهقول ده من كده إن أنت ليبويد نمونيا، صعب جدا. The diagnosis of exogenous lipoid pneumonia based on a history of exposure to oil, radiological finding of pneumonia in keeping with the disease, presence of lipid-laden macrophage on sputum or bronchoalveolar lavage. Chest X-ray ممكن ألاقي يعني بتحمل كل الاحتمالات، diffuse confident consolidation الموست common، bilateral poorly defined opacities، irregular mass-like lesion ممكن يحصل coalescence من الكونسوليديشن تبان في صورة ماس تخش في الديفرنشال بتاعت برونكوجينيك كارسينوما، bilateral symmetrical reticular nodular pattern لو حصل deposition في السمول ايرويز ممكن يعمل لي picture of tree bud، mixed alveolar and interstitial pattern بتبقى unilateral او bilateral حسب الاسبيريشن راح فين، commonly بتبقى في البيز في اللور اند ميدل لوب، طبعا زي اي ديزيز بيبقى سببه اسبيريشن. ده طفل صغير، ده الشيست اكس راي بتاعته برضه كان تشخيصه ان هو ليبويد نيمونيا، ده سنترال مور ذان بريفرال. السيتي تشيست برضه بيحتمل كل الاحتمالات من كونسوليديشن من جراوند جلاس نودوليشن كريزي بيفنج زي الالفر بروتينوزيس ماس لايك ليجن، لكن كاركترستيك لو دققنا قوي ان احنا هنلاقي الكونسوليديشن اللي عندنا او الماس فيها ارياز اوف فات اتنيويشن قليل اقرب للاتنيويشن بتاع الفلويد. دي اشكال مختلفه، شكل كونسوليديشن بيزالي وسنترال او سنترال مور ذان بريفرال، ده شكل جراوند جلاس واشبه بكريزي بيفنج، ده شكل ماس ليجن، ده شكل ماس برضو جواها اللي قلت لحضراتكم عليه الفات اتنيويشن، يعني ماس وجواها فات اتنيويشن، والاتنيويشن ده بتاع الفات ديبوزيشن اللي جواها. اللافاج في حالات كتير بيبقى كاركترستيك وممكن يشخص لي لو انا حاطط في دماغي التشخيص ده، بيبقى وايتش اور توربت شبه الالفر بروتينوزيس، فات جلوبيولز اون ذا فلويد سيرفيس، شكله نفسه بيبقى مميز طبعا، شكل الفات على الووتر. Biochemical analysis can help to confirm the diagnosis when using fat stains. Cytological demonstration of lipid-laden macrophage is consistent with the diagnosis of exogenous lipoid pneumonia. False negative result في حالتنا may also occur. Both the presence of lipid-laden macrophages والfinding في حاجة اسمها high lipid-laden macrophage index، الاندكس او الريشيو ما بين الليبيد-laden macrophage والماكروفيج العادية برضو، بس الحاجات دي non-specific ممكن نلاقيها في diseases أخرى. presence of foamy macrophage with large cytoplasmic vacuole بيفرق لي الاندوجينوس من الاكسوجينوس ليبويد نيمونيا، وده مثلا برونكيو الفيولار لافاج عملنا له ستين بسبيشال فات ستين وده كان المنظر بتاعه. الهيستوباثولوجي ممكن بفاين نيدل اسبيريشن زي ما عمل في الاول، ممكن باوبن لانج بايوبسي طبعا هتبقى احسن، ممكن بترانس برونكيال لانج بايوبسي. الداي سبيسيفيك فور ليبيد وير فاكيول ار ستيند ان اورنج والسودان 3 وهكذا. Chronic exogenous pneumonia is characterized by the presence of lipid-laden macrophages fill and stent the alveoli and the interstitium. الكومبليكيشنز اللي ممكن تحصل لي ممكن يحصل secondary infection على الموضوع ده، ممكن الموضوع لو سيفير وبعد كده ending in fibrosis يدخل العيان في respiratory failure. التريتمنت no specific treatment for lipoid pneumonia. Currently no studies in the literature that define the best therapeutic option. كلها حاجات supportive لو محتاج اكسجين، لو محتاج antibiotic for secondary infection. ساعات بنجرب اللافاج بس ما بيجيبش نتائج كويسه قوي زي الالفيولار بروتينوزيس. ممكن كمان ندي ستيرويدز كانتي انفلاماتوري. يعني الهدف من الكيس دي ان هي كيس شورت، ما كانتش يعني صعبه قوي في التشخيص، لان في الاخر لما بنغلب بنلجا للبيوبسي والباثولوجي، لكن تو بي ان مايند واحنا بنتعامل مع بيشنتس عنده هيستوري اوف اكسبوجر الحاجات اللي بتسبب ليبويد نيمونيا. ثانك يو. لا اوفر اول البروجنوز بتاعها جود، يعني هيكيب ان ستيشنري كورس. شكرا.
شكرا جزيلا دكتور محمد سعيد. وبروسيد النكست كيس برزنتيشن استاذ دكتور احمد جزار، استاذ الامراض الصدريه في كليه طب بنها، هيديلنا الكيس برزنتيشن من بنها يونيفرسيتي.
بسم الله الرحمن الرحيم. مستر تشيرمان، دير كوليج، ليدز اند جنتلمان، هو استكمالا للديلما وبدون برضه يعني افكار ان الحالات الحاله هتقدم برضه داخله في نفس حاله ازمير وحاله القصر العيني بدون سابق ترتيب يعني.
القاهره ايد واحده زي الشعب.
Male patient 27 years old, farmer cigarette smokers of 20 cigarettes per day for 9 years. The patient presented on May 2011 by cough, expectoration of small amount of blood-tinged sputum but no dyspnea or wheezy chest. There was toxemic manifestation in the form of anorexia, loss of weight, night sweats and low-grade night fever. Clinical examinations, general and local examinations were free and no palpable accessible lymph nodes. Benign chest X-ray was ordered and revealed bilateral mediastinal lymphadenopathy with festooned appearance. So, what is your professional diagnosis for this? بناء على الهيستوري ده والتشست اكس راي، هل دي بالمونري سيركيدوزس ولا هيماتوجينس تيبركلوزس ولا ليمفوما ولا فانجس انفكشنز ولا برونكوجينيك كارسينوما؟ ويجري ان طبعا الكل مش على فعلا بايلاترال هايلر ليمفادينوباثي، الموست بروبل دايجنوز بناء على الكلام ده فعلا ساركيدوزس. النكست ستيب، هل الانفستيجيشنز اللي هاو تو بروسيد للحاله ديت عشان نوصل للتشخيص سي بي سي اي اس ار توبركلين تيست، سيرم كالسيوم و 24 اور يورين كالسيوم، انجيوتنسين كونفرتنج انزيم، سبيوتوم اكزامينيشن فور است فاست باسيلاي، سبيوتوم بي سي ار فور است فاست باسيلاي، فايبر اوبتيك برونكوسكوبي، سبايرال سي تي تشيست ويز كونتراست، ولا اول اوف ذا اباف؟ طبعا عشان نختصر الوقت اول اوف ذا اباف كل ده مطلوب يتعمل. بس عدى على اللي بعديه. اللي بعديه السي بي سي was normal, ESR was 65 mm first hour, tuberculin test was 22 mm and ulcerated. ودي النقطة بقى اللي ايه بداية الكلام، يعني مع الساركيدوز المفروض ما يبقاش توبركلين هايلي بوزيتيف وفي ulceration بالمنظر ده. السيرم كالسيوم و 24 اور يورين كالسيوم وير نورمال، angiotensin converting enzymes was normal, sputum examination for ast fast bacilli was negative, sputum PCR was negative. الفايبر اوبتيك برونكوسكوبي اوردر اللي كان العيان رفض وقال مش هعمل منظار خالص، سبايرال سي تي تشيست وكونتراست ووز اوردرد اللي اتعملت. يعني كل اللي قدرنا نطلع فيه برضه ما زادتش كتير عن البلين تشيست اكس راي البايلاترال هايلر ليمفادينوباثي. طيب بناء على الكلام ده الهايلي بوزيتيف توبركلين تيست والسريتد والتوكسينيك مانيفستيشنز يعني كلينيكال، وبناء على التوبركلين بدانا الانتي بيركلوس تريتمنت ان ذا فورم اوف ريمكتازايد اسامبيتول بارازيناميد، وبرضه حطينا ستيرويدز 40 مللي جرام بير داي with improvement of the patient general conditions within 1 month. بدا يتحسن، الفيفر بدات تختفي، الاي اس ار قلت، لكن العيان افتر that the patient stopped the treatment from his own. اول ما لقى الجنرال كونديشن اتحسن قطع العلاج منه لنفسه واختفى عننا خالص. بعد سنه after 1 year and on October 2012 the patient presented by another attack of frank mild hemoptysis. Temperatures was 38 degrees centigrade, pulse was 88 per minute, blood pressures كان نورمال، clinical examination برضه جنرال ولوكال فري، والتشيست اكس راي في المرحله دي اتعملت، وكان المنظر برضه هو يعني السايز بدا يكبر، لكن بدا يبان حاجه هنا كده في الليفت ابر لوب في ريتيكوليشنز هتبان اكتر في السي تي. طب بعد البروجريس اللي حصل ده يعني هنرجح حاجه من التشخيص هيتغير؟ ستيل برضه الساركيدوز هو الفيرست بريوريتي، ولا التوبركلوزس، ولا الليمفوما، ولا فانجس انفكشن، ولا بروجينيك كارسينوما؟ وبناء ان العيان يعني واخد علاج شهر واحد وبقى ديفولتر وقطع العلاج منه لنفسه ورجع تاني والسايز كبر. طبعا صح، واجري مع الفلور على بعضنا البوسيبيليتي بتاع التوبركلوز بقت هي الارجح، واعتبرناه كديفولتر بيشنت ورجعنا له الانتي تيبركلوز تاني وزودنا عليها. طبعا الانفستيجيشنز اتعملت كلها تاني عشان ما نضيعش الوقت. برضه كان السي بي سي نورمال، لكن الاي اس ار بقت اعلى 80. السيرم كالسيوم و24 اور يورين كالسيوم كان نورمال، والانجيوتنسين كان نورمال، والسبيوتم برضه ريبيتد نيجاتيف. وبرضه طلبنا الفايبروكتو برونكوسكوبي للمره الثانيه، هو الولد كان وحيد اهله يعني متدلع شويه وبرضه رفض ان هو يعمله للمره الثانيه، فاتعمل السبايرال سي تي تشيست. طبعا الليمف نودز بقت اكبر، وهنشوف في البرينكيماتوس ويندو الليفت ابر لوب انفلتريشنز.
لكن لغايه دلوقتي ما تعملوش سي تي جايدد بايوبسي.
لا هو رافض اي انترفنشن، فرجعنا له الانتي بيركولاس تاني وزودنا عليها 2 نيو دراجز، خد سيبرو واميكين وبدا فعلا يتحسن، لكن للمره الثانيه تاني برضه شهر اول ما شم نفسه بقى كويس ورجع شغله راح قطع العلاج واختفى عننا برضه. ستوب تريتمنت اند ديسابيرد افتر 1 يير للمره الثانيه بقى. And on 15/9/2013 he presented with another attack of frank massive hemoptysis about 100 cc, والبيشنت was admitted. في المره ديت اصرينا واهله اقنعوه، اتحجز admitted to the chest department at Penn University Hospital where chest X-ray was done. وهنشوف المفاجاه ان بدل ما كانت بايلاترال هايلر ليمفادينوباثي بدا يحصل ميد زونال كافيتيشن. طيب الصوره اتغيرت ولا ستيل التوبركلوز از فيري هاي بوسيبيليتي؟
لسه مصرين عليه.
طبعا واجري، وفعلا بدانا له بقى العلاج تاني، لكن
ده مريض مشاغب ده يا دكتور.
لا لسه المشاكل جايه، احنا ما بداناش المشكله.
لسه
عملنا كل انفستيجيشنز تاني، لكن في المره ديت وافق خلاص يخش وحده المنظار. عملت له المنظار fiber optic bronchoscopy was planned and revealed unhealthy congested hyperemic mucosa of all segmental and subsegmental bronchi on both sides. Ball was taken from both sides and sent for examination for fast bacilli direct smear وculture وcytological. Also biopsy was taken from the unhealthy mucosa of the right intermediate bronchus and the left main bronchus واتبعتت for histopathological examinations which revealed chronic inflammatory cell granuloma without causation. وكان الريبورت بتاع البال وقال البال فلويد ادانا برضه دايلما ثانيه وقال لي ان السيلز 11500 والبريدومينانت سيلز بوليمورف، يعني عكس ما متوقع ان انا المفروض الاقي ليمفوسايت، قال لي البريدومينانت سيلز في اللافاج بوليمورف. الكالتشر نون سبيسيفيك وسبيسيفيك وراح مطلع لي بال كالتشر فور فانجاي اسبرجيلاس سبيشيز، ده في البال فلويد كالتشر. في الفترة ديت على ما طلع النتائج in the hospital immediately after admission بدأنا له انتي بيركولاس برضه بناء على المنظر بتاع التشيست اكس راي والتوبركلين was given again مع برضه السيبروفلوكساسين والاميكين والاسترويدز. افتر ذا ريزلت اوف بال كلتشر لما طلعت اسبرجيلاس سبيشيز اضطرينا نزود انتي فانجل تريتمنت، قلنا حصل كومبليكيشنز انتي فانجل سوبر اد انفكشن على التوبركلوزس، فحطينا انتي فانجل تريتمنت in the form of itraconazole itracan 200 milligram every 12 hours was added to the above treatment. After 1 month treatment with anti-tuberculous treatment plus steroid plus antifungal, there was no improvement and the following investigations was ordered CT chest تاني. فكرنا بقى ناخد ميدياستينوسكوبي وميديستان الليمف نود بايوبسي عشان نوصل لتيشو دايجنوزس تيشو از ايشو. فاتعمل السي تي برضه طبعا البايلاترال هايلر ليمفادينوباثي والكافيتيشن مالتي لوكيوليتد. One day before mediastinuscopy, plain chest X-ray was ordered by cardiothoracic surgeon, and on its basis CT chest was done. اتعمل بين chest X-ray هنشوفها دلوقتي منظر تاني اختلف خالص، فبالتالي بدأ يبان فلويد ليفل في الكافيتي وفي كافيتي تاني هنا وفي فلويد ليفل برضه اللي هم كانوا بين في السي تي 2 كافيتيز، فبدأ يبان فلويد ليفل، فبناء عليها الجراح قال لا لازم يعمل لي سي تي تاني. اتعمل السي تي تشيست، ادي الفلويد ليفل وده البارتيشن اللي احنا كنا شايفينه في البلين اكس راي ان هم 2 كافيتيز هم 1 كافيتي لكن فيه سبتيشن جواها. On the basis of the chest X-ray والCT الكارديوثوراسيك سيرجن غير قراره decided to do small right thoracotomy وانترا اوبراتيف assessment of the right lung revealed amalgamated hilar paratracheal and azygous lymph nodes from which biopsy was taken for histopathological examination. Also there was huge intraparenchymal lung abscess. The report of cardiothoracic surgeon in the right lower lobe which was drained by suction and sample was sent for culture and sensitivity. Then the cavity was obliterated by Borulin 3+ in multiple layers. The decision for obliteration of the abscess cavity rather than right lower lobectomy was difficult. ده كلام الجراح انه intraoperative despite the patient was classically in need for right lower lobectomy but the right upper lobe was unhealthy and surrounded by amalgamated lymph nodes of unknown etiology which could be malignant. So طبعا ما فيش frozen section كانت موجوده افيلبل وقتها، عشان كده كان قراره ان هو ما يعملش right lower lobectomy of unknown etiology which could be malignant. So conservative obliteration of the abscess cavity was the optimal choice. The lung was tested using saline and there was no air leak. 2 intercostal tube drainage were inserted, one for the air and another one for fluids. Closure of thoracotomy incision in layers was done. ده الchest X-ray on second day post operative. ده after 1 week. ده اللي سي تي تشيست اللي اتعملت 1 ويك بوست اوبراتيف. طبعا الهايلر ليمف نودز فيجن وده التيوب، واحده منهم التو انتركوستال تيوبس. ده 2 ويكس بوست اوبرتيف. طبعا العيان في الفتره ديت كان ستيل على الانتي تيوبركلوس والانتي فانجل والاسترويد لغايه ما جات لنا الريبورت بتاع الهيستوباثولوجي بتاع الليمف نودز، فقال ميديستاينال ليجنز بايوبسي جرانيولوميتاس فانجل انفكشن. ف بعتناها لواحد تاني هيستوباثولوجيست السلايدز والبلوك يراها لنا تاني. وان كان هنا
بس دي للشهرة بقى يا دكتور احمد، كان المفروض قطعنا الاسم ده.
معلش سوري انا غطيت اسم العيان.
اسم العام مش مهم بس اسم الدكتور هيطلع مريض.
الثاني قال revealed chronic granulomatous inflammation the lymph node showed convoluted tubercles of absolute cells with numerous Langerhans giant cells and fibrosis, no causation necrosis seen, no evidence of malignancy seen. وقال mediastinal lymph node biopsy chronic granulomatous lymphadenitis consistent with TB negative for cancer, please confirm bacteriological study and rule out sarcoidosis. يعني بعد ده كله ما وصلناش لحل. وبناء عليها ان يعني وجود الفنجس انفكشن اللي شفناه في البرونكو الفيرال لافاج في الاول، والفنجس انفكشنز اللي هو شافها واحد من الهيستوباثولوجيست قال ان في ليمف نودز انجلفنج فانجاي، قلنا لا ده شور ان في فنجس انفكشن بالاضافه للتوبركلوز. طيب ذا بيشنت كونتينيود ذا سيم تريتمنت بات قلنا خلاص مفيش ريسبونس للاتراكينازول. اتراكان بعد شهرين ونص was replaced by amphotericin B 50 ملغ per day intravenous infusion with 5% dextrose saline over 6 hours for 2 weeks. لكن after 2 weeks بدأ يحصل elevation البلاد يوريا to 68 والكرياتينين to 2.3 ده ككومبليكيشنز للانفوترسين، وبناء عليه it was stopped. وبعد ما رجعت للنورمال تاني after 1 week renal function test returned to normal. فاضطرينا سألنا بتوع الانكولوجي فقالوا بندي حاجه اللي هو الفند الفوريكينازول وده سبيسيفيك وبيدوه هم كمان في الكيموثيرابي عندهم، فقال لي ده فيري افكتيف. فبدانا الفند 200 ملغ بير داي افري 12 hours was given every 12 hours for 8 weeks with marked improvement. والانتركوستال تيوب وير ريموفد بعد ما العيان اتحسن. طبعا هو بياخد الانتي فانجل مع الانتي تيوبركلوس والاسترويد. وده كان التشست اكس راي، بدات الليمف نود تتحسن. After 2 months from the start of treatment, the patient continued on remactazide 600 mg per day and discharged from the hospital for follow-up in outpatient clinic every 2 weeks. العيان اتحسن ورجع شغله. اللي مش موجود هنا بقى ان العيان بعد 4 شهور بعد ما رجع الشغل بقى كويس وجين ويت وكل التوكسيكولوجيز، جالنا الاي سي يو بكارديوجينيك شوك بعد 6 شهور. اتعمل له امرجنسي ايكو، فقالوا في ليفت انترا اتريال ماش او ثرومبس او ماس مش عارفين ايه، فقالوا ده محتاج امرجنسي على طول يتفتح دلوقتي، لكن هو بيتنقل اسم جراحه القلب مات.
الحمد لله.
بعد 2 كيلو بسبوسه، بعد 2 كيلو بسبوسه.
طب الاوتوبسي بيه بعد
وات از ذا فاينل دايجنوز؟ هل بقى ديت البلمونري ساركويدوزس كومبليكيتد؟ لا مفيش اسئله ثانيه. يعني الدايليما هنا بقى يعني موضوع الهايلي بوزيتيف تبركلين والالسريتد وان ديت تبركلوزس والسيكونس اوف ايفنت، يعني ليفت ابر انفلتريشنز وبعدين رايت ميد زونال كافيتيشن، يعني ماشيه في سكه التبركلوز صح. طب وجود الساركويدوز ومفيش كازيشن في الليمف نودز، هل ممكن يبقى الساركويدوز كومبليكيتد مع التبركلوزس والفنجس انفكشن جه اون توب؟ اضطرينا ندور في الليتريتشر طلع الكلام ده موجود. فبالمونري ساركويدوز كومبليكيتد باي فنجس انفكشنز ولا بالمونري تبركلوزس كومبليكيتد باي فنجل انفكشن ولا بالمونري تبركلوز اند ساركويدوز كومبليكيتد باي فنجل انفكشنز ولا بالمونري من الاول خالص؟ ناس قالوا لا ده هي من الاول كانت كلها سكه فنجل انفكشن، ولا بالمونري فنجل انفكشن فروم ذا ستارت، ولا نان اوف ذا اباف.
ما الاسبرجلوما فانجل هول في كافيتي.
هي فانجل كومبليكيتنج التوبركلوزس، والتوبركلوزس جاي معاه يعني
وفانجل
بالظبط. الليتريشر لما رجعت لها قعدنا ندور، فلقيت في ساركويدوز اوف ذا ابر اللي انا شفناها الان هيلثي ميكوزا بتاع التراكيو برونكيال تري موصوفه. ساركويدوز اوف ذا ابر ريسبيراتوري تراكت اند برونكيال تري يوجوالي ليدز تو هايبريميك اند جرانيولار ميكوزا which will cause epistaxis and hemoptysis. ده الكلام ده منشور سنه 84. الكافيتي فورميشن ان بالمون ساركويدوز اتوصف برضه في سنه 55. والاسبرجلوما كومبليكيتنج ساركويدوز ابروسبكتيف ستادي في 100 كيسز، ده 12 سنه 84 في التشست. ثانك يو فيري ماتش.
Very thanks Professor Ahmed Al-Gazzar for this interesting case. And question Professor مختار مدكور، اتفضل يا فندم. المايك لو
the case of atypical acid bacilli, you should search for atypical acid bacilli. So long there are glands amalgamated and the tuberculin test is highly positive, you cannot exclude mycobacterial, whether typical tuberculosis or atypical tuberculosis. The bacteriologist or the pathologist should search for atypical acid bacilli. And I proposed yesterday that atypical acid fast bacilli is not studied in Egypt. We only reported few cases, and I think this case is of atypical acid fast bacilli, which usually do not respond to the usual treatments. Thank you.
Now we are going to be enjoyed with another case presentation. Professor Islam Ibrahim. دكتور سيد. فين يا باشا؟
Well,
دكتور سيد سالم، اتفضل يا فندم.
this case مع اخواننا في الازهر. And the first diagnosis of sarcoid was definitely not correct because the tuberculin test was highly positive and ulcerative, and hence the steroid therapy was not really indicated, and it was a possible immunocompromisation with the invitation to the fungal infection. And I absolutely agree with Professor Mukhtar Matkour that it can be one of the MOT, that is the mycobacteria other than tuberculosis, and it should have not been given steroids. And although I witnessed the case with them, and the patient was again to be blamed because he was a non-complying patient for 3 consecutive times, and hence don't blame yourselves, but that's it. And there is always what we call GOK, God only knows.
Very thanks our great Professor Said Salim. Any question? Professor Islam.
Assalamu alaikum. Well, unfortunately, my case is not that funny, but I'll try to wrap it up. I might go over time just a little bit. I was supposed to describe a case from Saudi Arabia, but instead, coming from the West, I got you a case from UCSD. This is a patient who presented with dyspnea. And the story is, 53-year-old male with history of pulmonary fibrosis on chronic prednisone. He comes in because his dyspnea is worse. It had been progressive for 5 months, associated with intermittent cough, production of some clear sputum with no hemoptysis. He went to many doctors, got many courses of antibiotics, didn't get better. His review of system is positive for the following. I thought the most striking was a loss of a 20-pound weight loss over those 5 months. He denied fever and chills, but he did admit to having some night sweats. He also reported some swelling of his legs. And he also noted hoarseness of voice for the duration of the 5 months since he started getting worsening dyspnea. His past medical history, he was diagnosed with pulmonary fibrosis 20 years prior to his presentation to ESSB. He had a transbronchial biopsy, but he doesn't know the results. Most likely it was non-diagnostic, and he had no further records. He also complained of some GERD, but he did mention his left vocal cord, for which he had a CT of the neck that confirmed the presence of a medial shift of his arytenoid cartilage and vocal cords, confirming the presence of vocal cord paralysis. His father had some sort of unknown lung disease, most likely fibrosis, diagnosed when he was 50, and then he died at age 74. His mother also had an unspecified lung disease, passed away very early. She was only 36. His brother had asthma, so he comes from a family that has pulmonary diseases. Socially, he was born and raised on a farm in Mexico, in that little part on the map called Zacatecas. He moved to San Diego in 1977. He reports a very transient smoking history. 1 pack per week for 2 years when he was a teenager, and then he quit. He worked in construction, no pets, and no hot tubs. Medications, he had been on prednisone for a long time, 5 milligrams, and ranitidine for his GERD. Physical examination, he has mild tachycardia, he's hypertensive, but notably he is hypoxemic on room air, which quickly corrects on supplemental oxygen. Saturation goes up to 95%. The rest of the examination, again, revealed hoarseness of his voice. He had a hollow systolic murmur at the lower sternal border. He had some congestion of his jugular veins. He has diminished breath sounds on the right side with dullness to percussion. Abdominal examination unremarkable. Extremity examination remarkable for his spitting edema, which is +2. Laboratory tests, chemistry, unremarkable. CBC, unremarkable. Liver functions, unremarkable. Coagulation profile, fine. CRP is elevated, 62. ESR is elevated. ANA test is negative. HIV test is negative. This was his ECG from a couple of years prior to his presentation. And this was his new ECG on presentation, showing evidence of right ventricular enlargement. As you can see, these tall R waves, and a right axis deviation with a right bundle branch block pattern. This was his chest X-ray. Remember, on exam, there was no breath sounds on the right side. It was dull to percussion, so obviously there is massive effusion, probably a mix of effusion and atelectasis, because the mediastinum is not really pushed that much. This is a lateral view showing the same thing. We're going to stop here for a minute and reflect on the history and physical and think about the several possibilities. Is this pulmonary TB? He's from Mexico. He grew up on a farm. He worked in construction. He has some sort of familial history of lung diseases. Is this a fungus? Could this be lymphoma? Does he have anything in the work history to suggest mesothelioma or asbestosis? Could this be pneumonia with empyema? Or is this simply congestive heart failure? I'll let you think about it as I proceed. Which diagnostic test would you like to order next? Any suggestions?
CT, high resolution CT.
Okay, I thought instead of giving you options and giving you choices, I will leave it open-ended, and if you ask for a test and I have it, I'll show it to you. And I have a list of all the tests.
Any suggestion?
Any suggestions?
Investigation من غير voting.
What would you like to see next? Pleural tab.
CT.
CT. Okay. CT is slide number 17, and I'm going to show the CT.
High resolution CT.
CT again shows similar findings as found on the chest x-ray with massive effusion, but you also see this ground glass appearance throughout both lungs. Some atelectatic changes here in the lingula. This is a mediastinal window, and I want you to pay careful attention to this window. I'm not going to give you the tip that is on that CT, because that is going to give the case away, but please take notice of some findings in the mediastinum.
Yes.
Of notice, the pulmonary artery size is big, almost like 1.5 times the size of the aorta, 4.3 centimeters, indicating some sort of pulmonary hypertension. Okay, so that was the CT. What was the text requested after that? Pleural tap. Very good. Biopsy right away or just a pleural tap? We will look at the fluid first, right? Okay, here we go. So this is the pleural tap, pH 7.52. Protein is high compared to the serum protein. LDH is certainly very high, so you know it's now exudative. Glucose is fine, probably not empyema. Cholesterol, and look at that number, triglycerides. So what are we thinking right now? We're thinking chylothorax, right? And chylomicrons were positive on microscopic examination, confirming the nature of this chylothorax. This is the rest. The cell count was 500, half of which were lymphocytes. So we have lymphocytic, exudative, pleural effusion, chylothorax. Now the rest is not very important. Gram stain didn't show any organisms. Cultures were consistently negative. Negative for bacteria, negative for fungus, negative for TB. Cytology was also unrevealing. No atypical cells, no malignant cells, just some reactive inflammatory cells. Which test would you like next? What do you want to do at this point? Or management decision. What would you like to do? We have a chylothorax now. Okay, I have a list of all the investigations and I'm just waiting for someone to suggest. So far we've done the pleural tap, we've looked at the CAT scans. Any other lab tests or imaging studies or even intervention you'd like to do? Yes, please. I cannot hear you. Serum LDH? Okay, it was high. The pleural fluid LDH was very high, confirming the exudative nature of the fluid. Okay. Tuberculosis. Okay, very good. So I'm going to go to slide number 28. Looking for TB. Quantiferon gold was negative. AFB smears and cultures were consistently negative 3 times. So this pretty much rules out TB for practical purposes at this point. What else would you like to do? We have chylothorax. Don't forget, we have chylothorax.
Thoracoscopy.
Okay, thoracoscopy. Would you like to immediately go into the chest cavity and get some biopsies? Head CT. Oh, PET CT. Abdominal ultrasound, looking for lymphadenopathy. Okay, MRI of the chest. Okay, that I don't have. Okay, who wants an echocardiogram? Anyone?
Picture of precardial effusion.
That's right. There was some pericardial effusion. Who wants to see an echocardiogram? Okay. We'll go for an echo, which is slide number 31. Here is the echo report. Normal LV function with some concentric LVH. He's hypertensive. Mild diastolic dysfunction, very common. RV hypertrophy. That's important. Normal RA and LA size. The right ventricular systolic pressure is very high, 81 millimeters of mercury. The IVC did not collapse on inspiratory movements. So that means the patient is not hypovolemic at least, so it might be even fluid overloaded. So that's the echo. So what do we know so far? It's most likely not left-sided decompensated congestive heart failure.
Look at the nails.
Look at the nails. They were fine. There's no clubbing, no yellow nail syndrome.
How about MRI?
I don't have an MRI.
Lymphangiography? Lymphangiography.
Lymphangiography. Okay, that was not done.
Mediastinoscopy.
Okay, we're getting more invasive now. How about an EBUS kidney? Would you like to see that?
Yeah.
Okay, that was slide number 32. It was tried. It was technically difficult. It was non-diagnostic. Okay, I do not have an abdominal ultrasound, but there was an abdominal CT, which I can mention there was some lymphadenopathy with calcification. There was on the CT supraclavicular lymph nodes. Biopsy was done, was non-diagnostic.
دكتورة دعاء عايزة تقولي حاجة؟
Okay, any other suggestions? Any more labs? Would you like to see any more labs? Okay, people are getting itchy to go invasive, right? Medical thoracoscopy. All right. You don't want any serologies, any collagen vascular workup? Anyone thinking of that? Okay, well, let me give you some serologies then. Slide number 29. Fungal workup. Coccidiomycosis. By complement fixation and immune diffusion, both negative. Cryptantigen, negative. Histoplasma urine antigen, negative. Does that make it any easier? All right, I might as well give you what I have. Anybody wants to see pulmonary functions at this point? It's not going to help, right? And it was not really very helpful, but I'll show it to you anyway because the patient had it done. And it showed mixed obstructive and restrictive pattern as you would expect. He has effusion, but the question is, why does he have obstructive changes? I'll let you ponder a bit on that.
What is the color of nails?
Normal.
قالها يا دكتور محمد.
Okay. So let me go back to show you the sequence. We looked at the X-ray. We looked at the CAT scans. We've been thinking about some differential diagnosis. Get a close look at that CT because it does have the clue. Okay, we looked at the pulmonary hypertension and the enlarged pulmonary size. We looked at the pleural fluid, tumor markers, negative, TB, negative, fungal workup, negative, PFTs, not very helpful, echo, nothing much. Tried to get that lymph node with EBUS, didn't help. Okay, so what did we do? A chest tube was inserted to drain that pleural effusion fully. The patient was kept MPO, he was diuresed as well, and he was placed on TPN because of the chylothorax. Later on, chest tube was removed, and we went for VATS. During VATS, thoracic duct was ligated, a mediastinal biopsy was obtained, a pleural biopsy was obtained, lymph node biopsies are obtained, as well as talc pleurodesis. I would say the patient got his money's worth in that procedure. This is what the pleural biopsy showed. Benign pleura, fibrotic, chronic inflammation. Totally unhelpful. What do we do next? With that successful pleurodesis, the patient felt better. Symptoms resolved. He was discharged home. A couple of months later, he shows up again with worsening exertional dyspnea. This time, his edema is worse. And he did not report paroxysmal nocturnal dyspnea before, but now he's orthopnic and complains of paroxysmal nocturnal dyspnea. Something is telling me he's developing pulmonary edema. No fever, no chills, no sweats, no hemoptysis. This is his repeat chest X-ray. As you can see, this is the remnants of the pleurodesis on the right. The effusion did not recur, but there is obviously some thickening of the pleura on this side. But now there is development of left-sided pleural effusion. So what do we do? Okay. CT ruled out PE. He had CT angio, which was negative for PE. This is the effusion again. CAT scan was repeated. The CAT scan again shows accumulation of fluid on the left side. Again, remnants of the pleurodesis on the right. There is still some small pericardial effusion, enlargement of the pulmonary artery as we saw before. Okay, we tap the patient for the second time, this time on the left side. But this time the fluid is much different. It is not exudative as it was. Protein is much less, LDH is much less. We don't have the high cholesterol and triglycerides that was on the right side. So this is basically transudative effusion. We look at the cells, again 500 white cells, half of them are still lymphocytes. And again, all the microbiological work is negative. Gram stain, negative for fungus, negative bacteria, negative TB. Cytology, again, not helpful. No atypical cells, no malignant cells. Kidney biopsy.
Repeat echo. Repeat echo.
And repeat echo. Okay?
ANCA B and ANCA C.
Okay. ANA was negative. Yeah. Collagen workup was negative. Repeat echo didn't show any changes. Okay. Now he is managed with left-sided thoracentesis, as we just saw, and he was diuresed again. He responded. He felt better. He goes home again and comes to the clinic for outpatient follow-up. But 1 month later, he again comes back with the same symptoms. And this time he goes into the ICU, spends some time in the ICU because of hypoxemic respiratory failure. Again, diuresed. And again, thoracentesis. Now, this time, somebody takes a hard look at the CAT scans and goes through the CAT scans and finds this thing here, which is basically the whole clue to the case, and recommends a TEE. Sorry, this is missing an E. So he recommends a TEE to further examine what you see on this CAT scan. What do we see on the CAT scan? Now, on the previous CAT scans, all of them, we noticed the calcified lymph nodes in the mediastinum and the hilum, and we even saw some more calcification within the mediastinum itself. These findings that started in a peritracheal, lymph nodes, mediastinal, hilar, and the mediastinum itself was fibrosed and calcified. So we go back to this CAT scan, and we find that these are the pulmonary veins as they enter the left atrium, and there is a complete blockage in this area, caused by calcified granulomas and lymph nodes as a part of fibrosing mediastinitis. TEE confirms that there is stenosis and obstruction of the pulmonary veins at the junction with the left atrium. Again, the patient does a little bit better with diuretics. And at that time, we get the biopsies from the mediastinum, which shows fibrosis invading the fat of the mediastinum. And we get that surprise in the lymph node biopsy taken from the mediastinum. This is the lymph node biopsy, and this is the offending agent, histoplasma. So this is a case of histoplasmosis causing fibrosing mediastinitis. There was no SVC syndrome. So I'm going to give you a couple of minutes on fibrosing mediastinitis, if I may, also known as sclerosing mediastinitis. Majority of the cases are because of histoplasmosis. Although only 1% of histoplasmosis progresses to cause fibrosing mediastinitis. Usually you get the infection and stays there for a long time asymptomatically, but it manages to infect and form granulomas in the mediastinum. And when the inoculum of the histoplasma spills out of the lymph node into the mediastinum, there is an intense reaction to that spillage of the histoplasma. Hence, there is fibrotic response in the mediastinum. So it is a hypersensitivity type of reaction. Now, there have been case reports. It's not a very common disease. And this is what it looks like on pathology. As you see, the mediastinum is all fibrosed. You cannot really distinguish a blood vessel from a bronchus. That's why it's a surgical nightmare. Surgeons cannot really dissect into a fibrosed calcified mediastinum. That's why there was no surgical solution for this patient. Epidemiology, the largest series recorded only 94 patients over a period of 9 years. So you see how rare that is. Mostly Caucasians with slight male predominance. And the presentation is very variable depending on where the fungus is going to form its granulomas. If it hits the esophagus, you might get dysphagia. If it hits a bronchus, you get the obstructive pattern. You can get atelectasis, you can get constrictive pericarditis. It all depends on where the fungus would form its granulomas. Also, SV syndrome, as mentioned, is one of the manifestations. How do you diagnose this? It is usually delayed. It takes 2 to 5 years to make such diagnosis. As it did in this case, it took a long time. And usually it is on the basis of radiographic imaging. But again, the biopsy, something we need to remember. Going after biopsies could be very comorbid because the mediastinum is so convoluted together, so fibrosed, so calcified that attempting to take a piece with biopsy can actually lead to death. These reports in the series, 2 deaths reported during bronchoscopy because of hemoptysis and massive bleeding, and 1 died during catheterization. The chest X-ray is again non-specific. You can see consolidation, you can see evidence of pleural effusion as we saw. You see the hilar, the mediastinal lymph nodes, CAT scan, same thing. But the calcification is something that can give that diagnosis away. Again, MRI is helpful because it will show the fibrosis of the mediastinum. Treatment, there is no curative treatment. It is, as we said, hypersensitivity reaction to the fungus. So it's probably too late in that game to try to kill the fungus, even though some reports say the use of itraconazole for 12 months had been reported in some cases to be helpful. And tamoxifen, again, some case reports. But usually there is not much you can do for that patient. Prognosis, uncertain because again the series is very small. There had not been too many studies, but usually poor. Thank you so much. I hope you enjoyed it.
Thank you so much, Dr. Islam. ما شاء الله as usual very interesting. متاسف دكتور مختار انا ما اقدرش اقول يعني ارفض طلب لحضرتك بس احنا متاخرين اكتر من ساعه. فحضرتك بقى تناقش الدكتور اسلام في البريك انا اسف جدا. Last case in this session كيس من جيراننا من السودان وصديقنا العزيز الدكتور عمرو الجايري. اتفضل دكتور عمرو.
Thank you very much, Mr. Chairman. And first of all, I would like to thank the organizing committee for giving me this opportunity to present my case. But I think all of us are hungry and very And I will go repeat. Okay. This is a case presentation from our hospital. This is a first question. Where is this? Is it in Sudan or in Egypt? In Sudan? Are you sure? No, pyramid in Egypt, not in Sudan. In Sudan? Okay. أنا بفتكر إنه الحاجة اللي بتوحدنا يا جماعة التاريخ والوحدة بين السودان ومصر إلى الأبد، لن يفرقنا أي شيء يربطنا النيل ويربطنا هذه الإهرامات. نعم. وقد يعني كانت السودان ومصر وحدة واحدة منذ الأزل، منذ هذه البيراميدز. And who is this? Who is this? All of us know this is Professor عادل خطاب. And who is this?
دي عندي في العيادة والله يا دكتور عمر، عندي في العيادة.
And there is many of our colleagues, Professor Ahmad Qurra'a and Yasir and Ashraf, all of these colleagues, they came to us in our conference.
الزقازيق ملهاش نصيب.
My case is a 32 years old lady referred to our hospital complaining of epigastric pain, dry cough for the last 6 months. On clinical examination, there is absent air entry on the right side. Routine investigation were within the normal limits. This is her chest X-ray. First, what is the radiological abnormality? Is it right-sided pleural effusion, right lung collapse, pleural mass, mediastinal mass, or right lung consolidation?
هات الصورة تانية يا دكتور عشان الزملاء يعني. بريفيت.
Please vote. Right side pleural effusion is the majority of this, but I think by this X-ray we exclude that this is not a pleural effusion. This is not a typical case of pleural effusion. As we know that the typical pleural effusion we see the crescent sign, and if we look to the X-ray, it is not a pleural effusion because if it is massive pleural effusion, we will see that the mediastinum is shifted to the other side, the trachea and the heart. And if we look to the X-ray, we see that the trachea is central and the heart is not pushed. Also, it is not a right side lung collapse because the mediastinum is in place. It may be a pleural mass or mediastinal mass, and also it is not a lung consolidation. And we remember these two, pleural mass or mediastinal mass. This is abdominal X-ray in which we see that the tumor is extending from the chest down. It reaches the right kidney. And in this CT scan, we see that the left kidney is more higher than the right kidney. Also, the ultrasound of the abdomen reported that urinary system, left kidney is a super or is the upper or higher than the right one, which is poorly detected. There is a mass cyst in the right side above the liver. And this is a CT scan of the chest, which show a mass on the right side. As I said, that is extending from the chest up to the abdomen. And this is a CT scan. Left lung tissue is normal. There is a huge cyst in the right side of the chest. What is the most likely diagnosis on this stage? Is it hydatid disease? Is it bronchogenic cyst, loculated empyema, neurofibroma, or desmoid tumor? Please vote. %, with the hydatid disease and 20% bronchogenic cyst. Loculated empyema is 7% and neurofibroma 20, 0 for desmoid tumor. We will see later. We refer this patient to the surgeon and thoracotomy was undertaken. This is incision, wide incision, posterior incision. Huge mass with stamped rib impression. The tumor was found to extend vertically from the diaphragm up to apex of the thoracic cavity and from lateral chest wall to the pericardium horizontally. And this is the tumor. In a trial of aspiration, there is no fluid. Make a purse stir and make a hole. We discover it is a solid mass. It is not a cystic mass. And this is a bore. And the aspiration, there is no any fluid inside the mass. And this is the mass. The tumor successfully removed, weight 5 kilograms. The lungs, three lobes fully inflated in anatomical and physiological position. Chest tube size 32, attached with underwater seal. And this is lung after removal of the tumor, re-expansion of the lung. And also the three lobes of the right side are normally. And this is a tumor which is weight 5 kilograms. This is a part of the tumor. What is the most likely diagnosis? Fibromatosis, schwannomas, sarcomas, neurofibroma, or lipoma? Please. لا لا دكتور حسامة. What is the most likely diagnosis at this stage? Please vote. Okay, we will see. And this is the histopathology of the tumor, which shows infiltration of fibroblast. And the specimen revealed fibromatosis, and the immunological stain were performed, and cells were positive for Vintin and blood vessels positive for CD34. And the final diagnosis is mediastinal fibromatosis. And what is the next in heart treatment? Follow-up, chemotherapy, steroid, radiotherapy, chemotherapy, and radiotherapy. What is your opinion?
Any suggestions لأن الفوتنج مش شغال.
follow-up of the patient. Regarding her medication, we give her ranitidine, Bisidine in the after operation. 3 days later, the chest tube removed, and on the 8th day, patient discharged in a good condition, and we plan her for follow-up. 15 days later, 1 month, 2 months, the serial chest X-ray were all normal. There is evidence to support combined radiotherapy and surgery, but not surgery alone in the local management of the fibromatosis. Systemic treatment, particularly with non-cytotoxic agent, appear to be promising approach and should be evaluated in randomized prospective trials. In conclusion, fibromatosis-like tumor arise from the pleura and constitute about 5% of all pleural tumor and 2% of mediastinal tumor. Such tumor are usually solitary, and multifocal tumor are not commonly reported, and should always be considered as a possibility while dealing with intrathoracic mediastinal tumor. The disease is potentially curable if the diagnosis is early, and long-term follow-up of this patient is strongly recommended because the early detection of recurrence of the tumor. The young cell tumor represents 3% of all chest tumor, and is a tumor which is size more than 20 centimeters. It is an aggressive tumor, extremely fast growing, whatever being benign or malignant. Tumor of fibrous tissue, fibromatosis in the chest and mediastinum have been rarely reported in literature. These are rare tumor, initially asymptomatic, but later on the presence of symptoms, the size grow. The possibility of this rare entity should always be considered in patient with intrathoracic tumor. And in the last, I would like to invite you all to be in our PL of Sudan in March 2015, and thank you very much.
ثانك يو دكتور عمر، وبشكر الدكتور محمد عوض ابراهيم، وبدعو الاستاذ الدكتور طارق صفوت لبدايه الجلسه التاليه.